All right, so I am very excited to chat with Dr. Florence Comite. We're going to be talking about precision medicine, optimizing hormones. I mean, it's going to be a really fascinating call here. And so let me go ahead and give Dr. Florence's bio here. As Dr. Florence Comite is a clinician, scientist, and innovator in the field of precision medicine. She is world renowned for her expertise in predicting, preventing, and reversing chronic disease and the disorders associated with aging. So in 2005, Dr. Comite founded the Comite Center for Precision Medicine and Health, where she practices a clinically proven academic approach to personalized healthcare, structured as a clinical trial, and Grok Health, a mobile app with science-backed AI and ML-backed systems to identify treatment and lifestyle changes to reverse and prevent the diseases of aging. So Grok Health, a revolutionary new app that delivers personalized precision medicine, again, to reverse biological aging, and it's currently in beta testing. So the application offers Dr. Comite's patients high personalized healthcare that interprets their genomic, metabolic, phenotypic, and digital health data into individualized action plans. The AI-powered app is being developed with the intent to expand the impact of precision medicine and empower people to take control of their health. And wow, I'm excited to check out that app. I think I listened on a previous podcast. It's not going to be out though until sometime 2024, which obviously as of recording this, we're pretty close to that. So, but yeah, very excited. And thank you so much for being here, Dr. Comite.
Appreciate being here. Florence is fine. Can I call you Eric?
Yeah. Oh, without
okay,
question.
Great. Well, since we're both from Brooklyn and Queens, I think we're related probably.
Yeah. All right. Well, awesome. Well, Florence, can you dive a little bit into your background? Were you, when you graduated from medical school, were you just like more like a conventional medical doctor, or did you always want to be more like integrative into functional medicine? Maybe just give a little bit more of your background.
I'd love to. And actually did start when I graduated, but maybe not quite in the way we're thinking. My father asked me when I graduated medical school, so can you now help me be healthy? And I was at Yale. So he said, my famous, Yale graduate, I'd like to know how to keep my health. And I looked at him a little confused and I said, no, medicine is about treating disease. And he said, well, that doesn't make sense. Didn't you try to keep people healthy? And I said, that's a great idea. So I think I went through training subsequently. After graduating from Yale, I stayed at Yale doing residency in internal medicine and hit several fields from medicine, which is adult, deep diving into adult specialty, pediatrics, and women's health, which also incorporated men's health, but more from a fertility point of view. And then I was at NIH, where I became a clinical scientist and sort of worked hard to look at research and how you bring a research scientific mindset. So I did a lot of research. I published a fair amount, went back to Yale, stayed on the faculty for 20 years, and began to realize about 20 years ago that that we all start aging in our 30s. And why don't we pick up on that and stop disease from happening before you get symptoms? So that started me on this path of proactively wanting to stop people both aging, which is a big risk factor for all diseases. And I felt like if I could both stop aging, it would also stop chronic diseases of aging. Because if you think about it, diabetes, for example, is one great disease that happens more often than not as people get older, like in their 40s, 50s, and 60s. But it's really beginning way before that. So I felt that if people could stay physiologically younger and healthier the way my dad described it and wanted for himself, that would be a gift, because why get sick if you don't have to? So that's how my work began in this field, from a scientific and also clinical applications.
Well, thanks for sharing. And you still, to this day, then do quite a bit of research?
I do. In fact, the center that I started in New York in 2005 was an outcome of that, because what I designed was something we now call at the Comite Center for Precision Medicine and Healthy Longevity as a individualized study of each human being. So we think of it as N of one. Most of medicine is population research, where you're looking at thousands, if not millions of people. And then you're applying it almost as a one size fits all, not individually to each human being. And that came at the same time I have this epiphany. I was giving a journal club at Yale, and like, why do we begin to fall apart in our 30s? So like, we're fine up until then. And in our 30s, fertility, men begin to get heart attacks in their late 30s if they have a proclivity to that. Women start more easily than men, putting some weight around the middle, slowing down in some ways. Energy becomes a factor, osteoporosis. And then that just begins to accumulate as you hit each subsequent decade of life. And I knew at the time, being an identical twin, that my twin and I were not exactly alike. And I always was interested in genomics. And it was around that time that the whole genome was described, looking at DNA. And I felt that it wasn't ready for prime time because you couldn't really peer into function in a dynamic way. So I began to study metabolism and endocrinological hormonal optimization to see, how do we stop people from getting older at the cellular level? How do we keep them in the best shape they can be in, which generally happens, not everyone, but most people in our 20s. So that is prime time. And I felt like if we could keep people physiologically in their 20s or no more than 30, we wouldn't be doing the Abby Hoffman thing. We're getting old in our 30s, because effectively we are. I think many of us blame it on having children, a family, being really busy, trying to make it in our career. But even if we did exactly the same thing as we did in our 20s, which, marathoners and triathletes are a great example of it, they still have heart attacks. Why? And so those questions occurred to me, along with the fact that each one of us is unique. And I knew that my identical twin and I are not even alike. For example, I could live on sushi and sashimi, and she doesn't like fish at all. And I, except for mackerel, which I always forget to say because we grew up eating herring, which is mackerel. It sounds amazing because it's very strong fish. So it's unlike tuna and salmon and all the rest of the delicious stuff. She's an amazing gardener. I can't garden. Our teeth are somewhat different. Our eyes are a little different. Our gut is a little different. So it didn't make sense to me. If we're identical twins, what's changing? And what occurred to me at the time is that it's expression of genes. And so that's what my research is about for the last 15 years. It's how we define N of one and how we figure out what's right. For example, for you, Eric, might not be right for your brothers. If you have brothers, I don't know if you have siblings, or your cousins, that even if the genes look alike, they don't always act alike. That's like in identical twins.
And so that is kind of tying into precision medicine, like what precision medicine is, just not, really everybody's difference is pretty much what you're saying. And so not everybody requires the same diet. Not everybody requires the same, even maybe stress management skills. And just, we could go beyond and beyond, obviously supplementation. So is that maybe you could give a better definition of precision medicine?
Exactly. You got it right. I can delve a little deeper. So the word precision for me comes from data. To me, without data about a human being and how they act at the cellular level, metabolically, hormonally, what their thyroid is doing, what their brain is doing, what their ovaries or testes are doing, you really can't tell people apart necessarily. And so the data is what I married to what I think of as the personal health story. Instead of what we typically do in conventional medicine is very reactive. You have to get sick and then we're good at it. We jump all over you, right? But that is reactive medicine. To me, it's about being proactive. I'm actually, unlike you, not trained in functional medicine, although a lot of my functional medicine colleagues and friends think I know functional medicine. But to me, the root cause of disease, which is kind of the core of functional medicine, has to do with the etiology and how genes are expressed. So precision to me is data married to somebody, how they live life, how they sleep or don't sleep, what their exercise is like, what they're willing to do to put effort into eating maybe a little differently. But I don't believe in suffering. Like, to me, if we get this right, we'll live even longer, like maybe till 120 or 150, but in great shape, but enjoying life. So it's not about suffering to do everything perfectly. It's not about fasting all the time or living on paleo or keto. It's about what's right for that singular human being. And so the Comite Center has been called a living N of one lab, meaning that it is really about a collection of people and data and people who want to invest in their health and own their own health trajectory. How do we stay healthy for the rest of our life and never get diabetes, never have a heart attack, don't get Alzheimer's, don't get a stroke, don't get cancer or osteoporosis? That's really what precision is about to me. The data to put into play interventions, actionable interventions that are fit for that specific human being, if that makes sense. I hope it does.
Yeah, no, it does make sense. And I guess that's where you're going with the Grok app that's coming out, like getting even deeper into the genomics. But I assume even now, like these days, you do genomic testing on patients?
Yes, we do. So I felt about a couple of years ago that we were beginning to reach a time where we could use genetic variants, meaning if your genes aren't exactly functioning right, what do those variants tell us? Can you detox mercury, which is something that happened in me that I found out that I'm not a great detoxifier. It puts me at higher risk for certain kind of cancers and also accumulating bad toxins like mercury, which in me was 38 when you want to really have it less than 10. In my twin sister, it was undetectable because she doesn't really live on fish the way I used to. So in 1 year, I was able to bring it down after identifying it, but I didn't learn until a couple of years ago when I looked at gene variants that are now we have operational at the living N of one lab, which is the center, that I knew that I don't detox well. And I need to be able to be careful what I do. For another example, which I'm not too good at, so I hope your audience can appreciate, they may feel the same way, is I don't have celiac, which would make it hard to digest gluten, which is ubiquitous out there in every slice of pizza and great bread, which I could live on too. And yet it's very hard for me to be gluten-free. So I go through periods where I try to be my best at it, but that inability to detoxify also affects me. And there are lots of examples of that. So yes, we're in genomics. And what Grok is, because you've connected the dots, is really taking a component of what we do at the center and delivering it to everybody on a virtual medical platform using an app for people to be able to upload their own data, to get, for example, a continuous glucose monitor to measure sugar, to look at their biomarkers. And there are 5 key ones that I'm happy to jump into that have come out of my research that make a difference in every single one of us, because we're all born of, men and women with genes that may not be perfect. And when they come together, it creates a unique human being. And by figuring out how we live life and what we do, we can change your future state of health by stopping chronic disease and actually reversing aging, which people stop me when I say that, but we have the data to prove it. I don't know how much you're into that, but I'm happy to also point you in the right direction and your audience to hear more about it.
Definitely interested. Would love to talk about the biomarkers, but I guess before you dive into the biomarkers, a quick question. Is it, when it comes to reversing aging, I assume the earlier you make these changes, the better. But for someone like me, who's, I'm 53, and, someone else who might be in their 60s, 70s, I guess, is it ever too late to reverse the aging process?
No, it's not. It's a great question. But if you look up rejuvenationolympics.com, which is a site that was started by someone who's gotten out there because he's spending millions on his own health to try to reverse aging in every cell of his body. He's in his 40s. Brian Johnson. Have you seen any of his work or heard about his work?
I don't think so.
So he created a website, and I think I'm not sure if it's a business, but blueprint.com. But he also set up this site called rejuvenationolympics.com, www.rejuvenationolympics.com. And you'll see that people are listed there who have reversed aging. And as such, we are 25% of the leaderboard Actually, Peter Diamandis and some of the other folks who believe in extending health and longevity are also part of it. But the Comite Center is 25% of the change, the top 20 of a couple of thousand people that have found it and upload their data. So I'm very proud of that because it's independent validation looking at biological aging. So that's the point I want to make along with your, is it ever too late? So it's far easier if you're younger because you have more, your system has more to it. It's like you can burn the candles at both ends as a teenager and 20 something. It gets harder 30 something. It gets even harder every decade. But then again, I've seen 70-year young people twice as healthy as 35-year young people. So it's completely up to that N of one individual and what's going on below the surface in their health story, how they live life, their family history, the choices they've made. And all of that is reversible and changeable. With the exception, there are some genes that are known to be autosomal dominant, meaning they'll express no matter what. A good example might be BRCA. 88% of people who have a certain kind of BRCA gene that causes breast cancer, prostate cancer, and a few others are more likely to express it. But it depends on how they've lived life and what they're doing to treat it. There are other conditions that are supposed to be autosomal dominant that are not, like Lewy body's Parkinson's, which Robin Williams had. Nobody diagnosed it. Actually, one of my cousins had it and sadly died at 70. You start with dementia and you then get signs of Parkinson's. And sometimes it's not diagnosed. It wasn't in my cousin for about 20 years. It wasn't in Robin Williams either. He was able to cover it up as an actor really well. So there are most things, though, believe it or not, are reversible. If you catch it at an early age, and even later, if you're willing to put in some effort in juggling your life, and everybody has to make those decisions, like I told you about me and gluten. On the other hand, I'm at high risk for macular degeneration, which is an eye condition where you don't have central vision. My father had it. I inherited the gene, as did my twin sister. And it turns out that by limiting vitamin A and not overdosing on vitamin A in certain fruits and vegetables that I love, it will help me avoid macular degeneration because it helps to precipitate macular degeneration. And by using sufficient amounts of vitamin D and making sure I absorb it, it's also, so that's kind of interesting, isn't it? Because vitamin A is great for the eyes, right? You think, you know, tomatoes, anything red, tomatoes, red peppers, carrots, all three of them I can live on. You know, I munch on tomatoes all summer. I mentioned my sister was a gardener, so is my mother. We grew up eating tomatoes like they were apples. And they are actually a fruit, by the way, but we think of them as a vegetable. So, so I avoid a lot of vitamin A now. I try to do it more in moderation. Instead of like 3 packages of 2 pounds of carrots in the chicken soup I make, I try to limit it to like 1 package of carrots because, you know, it's sweet. And so I like sweets. And that's an example. When you look at the Rejuvenation Olympics website, to go back to your question about being too early, too late, where the right time is, it's never too late and it's never too early. The age range for our clients, we don't call them patients because we want them healthy, but they're clients, and in GROC, they're members, is 15 to 73 on that site. So you can see the span is great. And we want it to be for everybody because I think if people own their own health, that's what GROC is about, then they won't get sick in the same way. They'll be able to protect aging, their health and their money, because being sick costs a lot of money, not only compromises life. And that's what should be stopped. And I believe it can be in this century.
All right. Well, that's awesome to hear. So thanks for sharing that. That was also, yeah, it was very interesting about the vitamin A because I would have thought the opposite. Like you mentioned, vitamin A is known for eye health. So you figure, hey, if you have the gene that predisposes you to macular degeneration, you want more vitamin A, not only through food, but maybe supplement. But it sounds like it's the exact opposite where you want to limit it. And even like beta carotene sources, not just active vitamin A, but Yeah. So anyway, very, very, very interesting. So thanks for
Yeah,
sharing that
exactly.
as
You're
well.
exactly right. You're exactly right. And yeah, there was even a study years ago in the New England Journal showing if you take vitamin E, but you only take one type of vitamin, it actually increases cancer. So I like to be aware. I like to keep people aware of what their nutrient makeup is. For example, you know as well as I do that that fat soluble vitamins can be dangerous. Too much vitamin A actually causes hair loss as well. You can overdose on vitamin A. So it's confusing out there. You go into any pharmacy and there's, how do you choose what supplements are right for you and good for you? And we believe in looking at the specifics that make up you as a human being to figure out, do you actually need D to pull in more calcium and strengthen your bones? But D is also a hormone that is a fat soluble, and you can't overdose almost on D. But most of us have too low D. I haven't met a person with D that's greater than 50, and a lot of people are in the 20s or even in the teens. And we want vitamin D levels to be 80, 60 to 80 is a nice sweet spot. And it's really good, not just for calcium and bones, which we all know, but it's actually a hormone that affects every cell in the body, and it protects the immune system, it protects the brain, it protects the heart, the thyroid. And so you want to be able to know these facts to be able to apply them for yourself.
Yeah, same here. I see a lot of people deficient in vitamin D, most people lower in vitamin D. And I'm guessing vitamin D is one of those top biomarkers that you mentioned earlier that you're going to
It
discuss.
actually isn't, because here's the thinking about it and around it. So vitamin D is really important. The one group of people you want to be careful of is people who are stone formers and make calcium. Again, that can be genetic, but it can also be from dehydration and not drinking enough water. And if you have it in your family, it just makes the odds higher. So vitamin D presumably is low in everyone. You actually can't get enough from the sun. We've lost that ability. Darker skinned people even more so. The data I've read and interpreted over the years has shown that if you want to absorb vitamin D from the sun, you have to be nude for an hour near the equator, and you probably can get some vitamin D. But I've followed people who live in New York and then go to Florida during the winter. I've only ever seen one person increase their vitamin D from sun alone. So you really need to take a supplement. So that would be something that everybody should take, but not a lot of it. Like maybe 1,000 to 2,000 a day of D3. And we believe it should be taken with K2, because otherwise you don't channel the D or the calcium into bone. You need the K2, which acts in the coagulation sequence. So there's some complexities around that, because if someone's on a blood thinner, you have to be careful when you take it. And so vitamin D with D2, of K2 rather, at a certain level, and a certain kinds of K2 is important to have enough calcium in bone to not get the calcium in breasts or in the heart or precipitating in the prostate or anywhere else in the body. And that's a good combination. It's not one of our top biomarkers because it's ubiquitous. I'm sure your followers who've had their vitamin D measured have seen how low it is, but sometimes the doctors don't know that. They don't know that a vitamin D of 30, just because it says it's okay on a Quest or a LabCorp range, is fine. It's usually not adequate. And there are many people who have osteopenia and are risk for osteoporosis that should have more calcium in their body as well. So we don't actually prescribe calcium ever. I haven't done that for 20 years because there's no need. If you have adequate D, you're going to mobilize calcium from your gut, and just make sure you have calcium in your diet. So does that answer your question a little bit,
Yeah, no, it
frills?
definitely does. Just to confirm though, you like to see in most people, if not everyone, the 25 hydroxy vitamin D levels at least 50.
At least 60, actually, 60 to 80. And if they go up to 100, no problem. But in people who are at risk of forming calcium stones, and sometimes people know they have kidney stones, but they don't know what kind, I would beware. Or if they've had an immediate family member, a father, a mother, a sibling, even a child, to just be aware that they need to undertake vitamin D, not overtake, not take too much, take less, because people who don't have stones can take like 5,000 international units a day. People who have stones in their family or they themselves have produced a stone, I'd be careful and I'd make sure to take 1,000 to 2,000, no more daily, and make sure that they drink a lot of water, to the extent that their urine is clear, that it looks like water. So that, forget counting, but if you know that you're peeing and it looks clear, that's a good sign, because you're staying hydrated, which helps to stop precipitation of stones.
All right. No, that sounds good. I could talk more about vitamin D for a while, but we definitely want to hit some of the other points, including those top biomarkers. So why don't you talk about those? There's 5 of them, 5 top biomarkers?
There's actually 5 that we found are most critical in everybody. And this is partly based on the research, in that there is no one person I've seen, and I've seen thousands over the years, who actually metabolize sugar effectively, who aren't on a trajectory to become diabetic at some point in their life. It could happen in their 30s, it could happen in their 90s. And that's because it's survival. So the 5 key biomarkers speak to hormonal optimization, cholesterol, and all the carbohydrate markers that can tell a person what's happening today and where they're headed for the future. So, because no one wants to become a diabetic, it's not a fun thing. And so if you can stop diabetes in your tracks, you're stopping, the risk of heart attack, stroke, even Alzheimer's. You're stopping the risk of kidney disease or eye, disease, skin disease, things like neurological disease, like paresthesias of the hands and feet, which I've seen even precede diabetes in people who don't even know they're pre-diabetic or diabetic. So the millions and millions of people around the globe with diabetes or pre-diabetes is, to me, an understatement. It's actually everyone, because it's a survival gene. If we couldn't put on weight when we fasted, or when there was a famine, or when there was the Holocaust, we wouldn't be able to pass on those genes, because the folks who lived through being cavemen, cave women, which all of us must come from that era, right, had to survive a winter that may not have fed them. So those genes are ubiquitous. There are at least 1,500 variants of sugar metabolism types of genes. And so we all have combinations of them. And so we measure fasting sugar, fasting insulin, and hemoglobin A1C. And I can talk more to the complexities and the combination thereof, if you like. But the other 2 biomarkers that relate but also have other impact is free testosterone and what we call cholesterol risk ratio. And that looks at a ratio of total cholesterol and HDL, or what a lot of people think of as good cholesterol. And the lower that ratio is, if it's less than 2, the safer you are. And so these are values that we consider critical biomarkers. In other terms, we call them lab tests. But biomarkers, to me, point out that they are data that help us define the state of your health today and where you're headed tomorrow.
So cholesterol risk ratio less than 2. How about those other markers, the fasting insulin, hemoglobin A1C, free testosterone?
So fasting sugar or glucose, during fasting, like after an overnight fast, sugar should be between 70 and 80. And that's a pretty tight range, but that's optimal. And that means your body has no insulin on board. So insulin should be undetectable, or less than 2 as well, which is the dimension of detectability in the lab studies. And both of them speak to how well you manage and metabolize insulin with glucose, rather, in the system. And we don't need any insulin if we haven't eaten for 8, 10, 12 hours. Actually, we don't need insulin if we haven't eaten for 3 hours. And if we have too much insulin on board, even greater than 2, 2 to 5 is sort of target range, but not optimal. But anything over 5 speaks to insulin resistance already, which means the insulin has been overused in a way, and it's not working as effectively as it should. And so you really want fasting sugar to be between 70 and 80, fasting glucose, insulin to be undetectable at less than 2. And then when you eat, insulin does go up. It should mirror glucose, and there are ways of eating to do that. And glucose should stay below 120. Now, there are reasons glucose might shoot up higher, like to 150 or 180, and they include some good reasons like exercise, but there are patterns that have to be interpreted. But if you eat a banana and your sugar goes to over 200, that's a risk factor. The fructose in a banana is not compatible with your system. It doesn't mean you never eat bananas, but maybe there's a way you eat bananas that keep your sugar below 120 and between 70 and 120, because I didn't mention this, but you don't want your sugar to go below 70 either. That's a risk for diabetes because sugar needs to be maintained in this tight zone to keep you optimal and to prevent chronic disease from appearing and sticking with you for the rest of your life, because sugar damages every cell of the body. We have another trick to it that your followers may be interested in, and that is we use continuous glucose monitors or CGMs so that people can really see, like I mentioned, the banana, and they can test it themselves. And they can see singular foods, like what they might eat, what that does to sugar, whether it's a carb or a protein or a fat or fiber. And then they could start mixing foods. And one of the ways we know that we can keep insulin and sugar in parallel together and protective of your health is by starting with a protein before you eat a carb, any carb. So protein, high fiber, or healthy fats like avocado, olive oil, those in balance will keep your body's absorbing and metabolizing sugar in a way that's the healthiest, that's optimal.
So if you have an undetectable insulin and your fasting glucose is between 70 and 80, is it safe to say that your hemoglobin A1C is most likely looking good, which should also be on the lower side?
That's a great question. It is, with one exception. If your sugar and insulin shoot up in patterns that are not healthy, like after a meal. So let's say you sit down and you have steak and potatoes and green beans with a nice salad on the side. And you have your steak, it fits in the palm of your hand. So it's the right amount of protein. You want to have at least 20 to 30 grams of protein at each meal, or when you eat and graze, it should add up to at least a gram of protein per kilogram per day. And a kilogram, for those who may not know, is 2.2 pounds. So if you weigh 60 kilos, which I think is about 130 pounds or something of that nature for the women out there, you want to take in at least 60 grams of protein a day. And that would be 20 at each meal if you're a 3-meal a person day. And if you're not, just keep track of it. You absolutely want to see what your sugar does after that. And that's where the CGM can come in handy. And I'm sure you've heard of all those companies that prescribe CGMs and then follow your food. It's not as simple as food alone, as you're probably getting the idea from all the information I'm kind of pouring out there. And if I'm doing too much too fast, tell me, Eric, because I'm known. I'm a New Yorker. We speak very fast here. And you can relate. But you're more measured, so I'm impressed. So if you eat food and your sugar jumps up to 250, even having mashed potatoes, then that's a problem. So you could look perfect fasting, but not necessarily what we call postprandial, which means after food. And so here's another tip. I don't actually call diabetes anymore, and I almost try never to call it type 1 and type 2. Because type 1 is an immunological disorder, and that is very different than what we think of as named type 2. But I actually call this a disorder of carbohydrate metabolism, because it is, and because all of us have one in one way or the other, because as I mentioned, it's Darwinian. It's about survival. If we couldn't put weight on our bones and fat on our bones when times are lean, we don't live through those times. Those genes don't get passed down. So we owe it to our ancestors for why food is plentiful. There are golden arches on every street corner, right? And we can have those delicious French fries, although they used to be more delicious. I've tried them recently and they're not so good anymore. I think they made them healthier. I'm not sure, but that's what I heard, that they're different. But anyway, and it's easy to put on weight, and it's easier to put on weight as we hit our mid-30s and beyond because the hormones are shifting. So you have to be careful. And in order to be careful, you have to know what your body is actually doing. So the more data you have about how you personally function, the better off a person's going to be, because they'll be able to judge accordingly. Does that mean you avoid all food all the time that causes your sugar to go up to 180, 200, 250, whether it's a banana or a bowl of ice cream or a cookie or cake? Absolutely not. And there are some people that can eat a banana and their sugar stays at 100 or 80, and they're alone, a banana alone. And there are some people who eat a bowl of ice cream and their sugar stays at 110, because remember, ice cream has some protein in it. And there are lots of different people. So there's a study out of Israel from the Weizmann Institute that showed that very clearly. They compared two people out of the thousands they studied. I think they studied 1,600 or so, thereabouts. And one person, sugar went sky high on a banana, but didn't do anything with a cookie. And the other person had a cookie and it went sky high, but the banana didn't do a thing. So it's about learning about you individually as a human being, that whole N of one concept.
Oh, that makes a lot of sense. And do you currently use a CGM on yourself, or is it just
all the time? No, it's right here. I have to feel for it because they're so tiny. I can show it. I don't know if people want to see it. Don't look at my triceps, though. They're not the best. I work on it, but I'm convinced I was born without triceps. I'm only kidding, but it's so hard. On the other hand, my sister has you see it right there?
I do.
Okay.
Yeah, thank you.
My sister has amazing triceps because she did more swimming than I did in her, years ago. And I don't swim because it gets your hair wet and it's hard to dry it when your hair is long. That's one excuse anyway. But I love rollerblading and she doesn't rollerblade. And so she has great triceps. So she's able to wear sleeveless clothes and look much better in it than I do. She's carved. So I guess as an identical twin, I probably can get great triceps, but so far I'm working on it. It's a work in progress.
Yeah. Well, I'm sure you'll get there. And speaking about, I guess, tying into muscle mass, testosterone, free testosterone. Testosterone is important for muscle mass. I mean, protein also, which you mentioned. So free testosterone, another one of those biomarkers. And what's an optimal range for that? I guess it probably differs with men and women.
It does, but we do have optimal. So there's a spectrum and we judge according to somebody's health, how they feel, what they're presenting with, why. In men, it's a little easier than women. We women, as you men probably know, are very complex. And each woman is really her own thing. Whereas in men, it's still the N of one, but you can look at change in men as they age over time. It's more linear. In men beginning in their 30s, just like women, testosterone falls by 1% to 3% a year. And we women have far less testosterone than men. That's why we're at higher risk earlier in life for osteoporosis and fracturing either our wrist, a Colles fracture, or shrinking, or curvature of the spine. Or hip fracture later in life. But you've seen plenty of men, I'm sure, walking around hunched over a walker because they have severe osteoporosis and their spine is collapsed. So 25% of all men and women will ultimately be osteoporotic. Just in men, it starts about 10 years later than women. So in women, testosterone should be between 6 and 30, but I'm talking about free testosterone. And why we women also put more weight around the waist. Women who do everything pretty much perfectly and have maintained their weight, frequently they're 35 to 45 and they come to see me because they put on 2, 3, 4, 5, 6 pounds, which is almost nothing for some other women, right? But in these women, they look great. They've done everything. They work out. They eat as well as possible, or they're just gifted genetically, which, by the way, is a thing. And that's because their testosterone is low largely. So I think of a woman I just saw and spoke to a couple of weeks ago, Sarah, who was in fabulous shape, but she was turning 43 and she wasn't happy because she had put on 5 pounds and her clothes didn't fit her right. And we put her on testosterone. We also found out at the time that she was osteoporotic, and that was only by doing a bone density test, which I recommend strongly for everybody, at least starting in their 20s, but definitely in their 30s, when you can make a real dent in growing bone. And within weeks, her weight had dropped. It was definitely related to the fall in testosterone because everything else was pretty much in the sweet spot. And so you really want to raise testosterone. And most women come in at less than 2, sometimes less than 1, which is tiny. We have 5 to 10% of what men have. In men, you want it over 180. And I'm talking about free testosterone, not total. And I'll tell you why in a second. So in her case, she went from 1 to 12 over a period of weeks to months. And her weight dropped almost immediately because she was doing other things, the other stuff she should be doing. And when I say that, it's not just eating protein, which I mentioned, at least 1 gram per kilogram per day for the 60 kilogram women. Let's say it's 60 grams, but it could be more if you're heavily into resistance training, which is a good thing because that's how we grow muscle. And those are the 3 elements that could really make a difference for aging, because without enough muscle, you can become sarcopenic, and that allows disease to creep in either from the outside in, like what COVID did for people who had comorbidities and had diabetes or had heart disease. When they were sick and they didn't have enough muscle and they had more fat and more visceral fat, they got sicker and they died more often than people without it. So if you were pre-diabetic, it was 8 times as likely for you to die from COVID because of the comorbidity than if you didn't have diabetes. Or pre-diabetes. So testosterone, 6 to 30, free. Other labs may have other levels. So it depends also on the units that get measured. We happen to use Quest. LabCorp might measure it a little bit differently. Endoscience a little different. So everybody could be a little different. So you have to look at where that is in terms of optimal. And then make sure you're taking adequate protein in your meal daily and doing resistance training at least 2 to 3 times a week.
All right, sticking to the topic of hormones, can you discuss the difference between hormone replacement versus hormone optimization? And does everybody with low testosterone or estrogen, progesterone, do they need hormone replacements in your opinion?
Okay, let me start with what is hormone replacement and what is hormonal optimization. So first, I started feeling uncomfortable with hormonal replacement right from the beginning as an endocrinologist and as a reproductive endocrinologist, because hormones was a very deep field of mine, along with peptides. I did a lot of research in my earlier years at NIH and at Yale in children who had early puberty using peptides, and in adults with women with endometriosis and fibroids. And with respect to that, we're not Mother Nature. We can't do what Mother Nature does and cause a woman to have week to week women's cycles change, women's symptoms change. In men, it's more every 100 days, every 3 months, their system, evolves. Sperm takes that long to be made, and testosterone goes up and down with response to what we call a negative feedback loop in the body, and there's more consistency in it for men. That shifts as men hits their 30s and 40s when they don't release as much testosterone. Their brain doesn't recognize that they're not making enough. And in women, it shifts as well, but based on their ovulatory cycle, or if they're on birth control pills. So to me, optimizing hormones means we can start addressing what Father Time starts taking away from us. And in our 30s, testosterone begins to fall, even before menopause in women and andropause in men starts hitting us, where ovaries stop performing, you can't make eggs, and men start drifting downward with their testosterone, but they're not recognizing it. Their brain hormones are low. So they can make testosterone, but their testes are not being told, this is how you make testosterone. This is the hormone. Hormones start falling, particularly LH and FSH. So the optimization is, how do we limit risk and improve health? Like the risk benefit ratio to me is how I apply doing clinical research with dealing with a singular human being. So when we do research, we look at risk benefit for a whole group of people. Like, how can we get them healthier by any intervention we're doing or testing? And how do we prevent side effects, right? So hormonal optimization is limiting side effects, but increasing response. And what is the best benefit? As I mentioned with vitamin D or the hormone D, that's what we do when we look at people at risk of stones. We don't want them to have stone, yet we want to maximize their health. So we compromise on the dose of D. And that's the same way I approach any hormone, including testosterone, estrogen, progesterone, or all the other various, pregnenolone, DHEA, DHT, all of them. And that's how we look at hormonal optimization. Does that make sense? Where we want to get the best out of it without the least risk, if that's what we need for that person.
Yeah, no, that makes sense. One thing I heard with men and testosterone, that because she said it starts declining in the 30s, would you be cautious about giving a male male in their 30s or 40s testosterone? Because I heard that they, if they're still thinking about having children, you would not want to give testosterone.
Actually, the opposite, because yes, the last question that you asked, would you think twice about testosterone if a man wants children? The most common way of giving hormones in this country for now, maybe in the world, is testosterone itself. But I have a unique approach to it. I actually use a hormone, which is a peptide hormone, not a steroid hormone, called HCG. Have you heard of it? Human chorionic gonadotropin. Yeah. It acts like the hormone that comes from the brain, LH, which I mentioned earlier, and tells male testes to make testosterone, because it triggers the Leydig cells in the testicle and says, hey, wake up, it's time to make more testosterone, you're drifting to sleep. Because the brain is not paying attention to low circulating testosterone. That hormone actually increases fertility. We use it to help men become fertile. Testosterone can suppress the testes itself because you're giving the hormone, right? So you're giving the hormone, the testes looks around and says, hey, you might not need any testosterone because it's on board already. It's not perfect that way. Men still make sperm. And if it was perfectly shutting off the testes, then you'd be able to use it as a birth control. But we've never been able to use testosterone as a birth control because it doesn't really shut down. But for safety reasons, I would not give men testosterone if they were trying to conceive children. But a lot of men in their 30s are not. And if they're at risk, which is less common than your 40s or 50s or 60s, we judge it accordingly based on those biomarkers. So if your T is low, whether you're 35 or 45 or 55, we're going to look at starting with HCG if the rest of the numbers fill that pattern. I can give you examples, and there's a whole group of men that we treat that have Ashkenazi Jewish background, or they're Indian and Asian, that have very early heart attack and stroke in the family. And a lot of times relatives, men and women, died early, like by 60, of heart attack or stroke. And they were sick beginning in their 40s. So we have a whole group of people we treat gingerly and looking at risk benefit to make sure that we don't let them go down the path of having a heart attack at 40 or 45 and die in their 60s. In fact, the very first person who tried grok in February of 2021 was somebody who had that history, whose father was Ashkenazi and his mother was Puerto Rican, and his numbers looked like a 50-something year young man. And maybe this time I should say year-old man. And he was already expressing symptoms of low testosterone which we hear about, or hypogonadism, meaning his testes weren't producing enough. His numbers were tested 3 times. They were quite low. His free T ranged from 50 to 70 instead of over 180. He was putting weight around the middle. He had less energy, less libido, and it was completely reversed within a few months.
Wow. All right. Well, thank you. Thanks for sharing that, Florence. Before we start wrapping things up, can you talk a little bit about thyroid? Like, what do you test for in your practice with your clients?
Yep, I do. I can. So thyroid is an important hormone as well. So our thyroid gland sits around our neck. It's kind of like, I don't know, it looks like a bow tie, I guess you'd say, the little knot in the middle, but there's 2 wings. 80% of people have abnormal thyroid function. And as we age, it's clear cut. But you can't just measure TSH. You have to measure free T3 and free T4, because again, that system is interactive. We create TSH from our brain, the pituitary. The hypothalamus at a higher level makes TRF, which is thyroid releasing hormone, which tells the pituitary to make TSH, which is thyroid stimulating hormone. And that in turn tells the thyroid to make T4. Interestingly enough, T4 is converted to T3, and T3 is the active thyroid hormone. So if you don't measure TSH, T3, free T3, and free T4 together, you don't know the relationship, because the range for TSH is 0.4 to 4 or 4.5. It's a humongous range. And insurance companies sometimes they only want that number. But you can have a high TSH or a low TSH, and your thyroid, your free T and your free T4 can be abnormal in not the range we want. And we look for a free T3 of 3 to 4-ish, and we look for a free T4 of about 1 to 1.5. And the balance has to be there. And I've seen lots of variations on that theme. I think we've come too far in a way, sometimes using lab tests, but I've seen many women and men who complain of classical thyroid symptoms like hair loss, weight gain or loss, constipation, ends of the eyebrows, losing hair, and slowing down in their thinking or speeding up heart rates. And those are variations on the theme of high thyroid, low thyroid. In women, menstrual cycles, it's actually interesting. It's the opposite. If your menstrual cycle is too heavy, it's usually related to low T3. If it's high, if you have higher thyroid hormones and they're too high, you can stop your menstrual cycle, or you have a very light cycle. And you know better than me, I'm sure, that thyroid affects every cell in the body as well. It affects the brain for cognition and memory. It affects the heart for rhythm and muscle and conduction. It affects muscle and bone. So being in that optimal range for all those 3, and I pay attention more to free T3 and free T4 than TSH, because that could be anywhere. The final thing is, if we do see a disruption, particularly where we suspect something called Hashimoto's thyroiditis, or an inflammatory process that's immunological, we will look at antibodies as well, because that's an autoimmune form of thyroid disease. Does that help?
It does. So you test, it's important not to just look at TSH. So I'm glad you test for the thyroid hormones, free T3, free T4.
Exactly.
And then if you're suspecting autoimmunity, you'll also look at the antibodies. So thank you for sharing that. And is there anything else? I mean, I'm sure there's so much you could cover, but any last words or anything that I didn't ask you that you wanted me to ask you?
Well, I'll add one more thing for thyroid, and then I know we have to wrap up, because it's been fun, and I know we might even be over the hour. And I know you might want to take a couple questions. So with thyroid, also be aware that you need to know what your free T3 is. A lot of folks do reverse T3. I don't find it as helpful, except maybe when people are ill. But some people, 20% of people, can't convert T4 to T3. And that's why they may need, if they're already taking thyroid hormone, but it isn't doing as much as they hope, like Synthroid is the most common, which is a T4, or it's a generic type, then they need T3. because 20% of people cannot convert genetically T4 to T3, and that's the active hormone. From famous words, I hope it's not last words, but on this interview, I think everybody could take care of their health so that they become knowledgeable with such, like, not that much data. If they can follow along and really invest in their health, it will pay off in spades, because getting sick is very costly and not much fun. So by understanding more about your personal history, your family history, your exercise, your sleep, even your restorative stuff like yoga, for example, or meditation, which turns off cortisol, one can really preserve their health and actually get younger biologically as they age, longitudinally and chronologically, right? And so I just hope we can deliver this to everybody by scaling the Comite Center through the virtual app Grok Health.
Yeah, and speaking of which, can you, well, of course, let people know where they could find you, and then also how they could get on the wait list for that app, because since it's not officially out yet.
Great. Well, they can find me on Instagram, on Twitter, or let's say X, on LinkedIn at Dr. Florence Comite, Dr. Florence Comite. We're posting there. We also post on Comite Center on Instagram and Facebook, and I think as well as Twitter, and Grok Health, GROQ Health. As far as signing up on the wait list, it would be going to grokhealth.com. The link seemingly may not be working right now, but we're trying to fix it. But we have close to 20,000 people already signed up. And a little tidbit, the Android, Grok Health is out there on the Android, and we're collecting anybody who signs up so that when we're ready to really open it up to direct to consumer, which is going to happen sometime next year, anybody who signs up on an Android will actually be at the top of the list. So that's a little, with the iPhone, you need an invite. With the Android, you don't. You can go to, I think, Google Play and download the app.
All right, that's good to know. So yeah, whether you have an Android or an iPhone, again, Android, you're on the top of the list if you sign up, and an iPhone, you said you need an invite. But either way, they'll visit Grok Health, GROQ health.com, correct?
You got it. Yes.
Wonderful. Of course, I'll put that in the show notes as well. And yeah, thank you so much, Florence. This was an amazing interview. I really appreciate you taking the time to discuss how to reverse aging as well as optimizing hormones.
Well, I appreciate it. And you clearly know your stuff. So it was great talking to somebody who's an educated, informed physician who can help sort out these thorny questions for people, because I think it's really hard to understand medicine. We're so complex, all of us. So thanks for having me.
Yeah, thank you. All right, so let's we do have a few questions.
Can I last a little while? Yeah. Okay, good. We're set. Yeah.
Okay, cool. I won't keep you too long. It is not, unless we get a flood of more questions. But Cindy's question here: why would a person who isn't in menopause have a low progesterone level?
They're not ovulating. So, or they're ovulating and it's not a good ovulation. So progesterone goes up mid-cycle after you ovulate, which is usually 12 to 14 days before you get your period, day one of your period. And it should be a nice healthy number, like greater than 3. And if it's not, it could be a questionable ovulation. It could be underlying not feeling well. So not every woman ovulates every month. So that could also be happening. In fact, as women hit perimenopause, which is usually in the 40s, but can start as early as 38 and as late as 55 or 58, actually. I've seen it in that complete range. There are months that we look towards when you do fertility work, good progesterone levels, and we know pregnancy is more likely that month because they're building up and organizing the lining of the uterus. So lots of reasons, but that's the main reason ovulation is not happening or not happening well.
Yeah. How about chronic stress? Like if someone's just stressed out and their adrenals are not optimal?
If we had another, like 2 days, I could talk about chronic stress. Absolutely. Stress has an impact on every aspect of our body. Our mind is involved in all the things we do. There are neurotransmitters and hormones that act in our brain and through our cells. I mentioned briefly in the podcast the hypothalamus, the arcuate nucleus of the hypothalamus and the pituitary. And with stress, it affects every organ of the body, particularly the brain. And so by reducing cortisol, you can cycle more regularly. And sometimes women who don't cycle at all, by finding ways to reduce cortisol, and the best way is meditation. You actually turn off the gene that leads to increased cortisol. So absolutely, it interferes with hormones we release at night. If we make too much cortisol, or it's the wrong patterns because it goes up and down throughout the day, then we don't make enough growth hormone at night. And if we don't sleep well, we don't do well either. So there's multiple variables that we have to look at. And cortisol is one of the hottest, I would think.
All right. Thanks for that. And this is just a thank you. Thank you for such valuable information. And then this question, what about high testosterone in women?
That's an interesting question. I would have to understand what the number is. But if, let's say, a woman's been told by a doctor, well, your testosterone's too high, there could be multiple reasons. The most likely is that the woman might have something called PCOS, or polycystic ovarian disease, or hirsutism. And while you don't always find high testosterone there, and they're quite variable, the spectrum of PCOS and hirsutism is not well defined. And it could be anything from you have every symptom of PCOS, which is usually classically little cysts in the ovaries, lots of little cysts, to no cysts in the ovaries, high blood pressure, high cholesterol, infertility, high sugar, or none of it. You can look perfect, or other women could be overweight. That would be the most common. Maybe in this day and age, taking too much testosterone, either as a cream, injection, or pellet, can also cause, I've seen lots of those cases, women who come to me, particularly with pellets, whose testosterone is so high, they're actually in the range of men. Or, and this isn't unusual, but I've seen it as well, some men take testosterone cream, and if they put it on their body, even if they put it in the right place, like shoulders and neck, and a woman touches them, that cream can be transmitted. I actually had a doctor, a plastic surgeon, and his wife come in, who was a nurse, and her testosterone was like 1,000, her total. Her free was like 200, because her husband would put on the testosterone at night, not wear a t-shirt to bed, and it would transfer to her. So you have to be very careful if you're with a person, a male, who, or, whatever the gender, perceived gender is, but if they're taking testosterone and they're taking it as a cream, not my favorite way for men. For men, testosterone is best taken as an injection or as a pellet because of the way it's metabolized. We don't have time to go into that, but creams are hard because they can transfer not just to women, but to children. And that would be more dangerous.
Yeah.
Even.
Okay. Yeah. Thank you so much for mentioning that. This next one, if you want me to quickly answer, I could, or if you want to
go right
answer
ahead. I'd love to hear your answer.
Yeah. So Jane, what comes first, hypothyroidism or Hashimoto's? And so, I mean, in the case of Hashimoto's, the autoimmune process could be underlying for years. So essentially the autoimmune process develops for, the antibodies for Hashimoto's, and then it could take 5, 10, sometimes 15 years before enough damage to the thyroid gland takes place where the person is becoming hypothyroid. So in the case of Hashimoto's, typically the autoimmune process will develop first, and then over a period of time, the person may develop hypothyroidism. So I don't know if you agree with that, but if you want to expand, or if that's it.
I totally agree with that. I wish we had more time. One thing I will point out, that a lot of times, you're exactly right. A lot of times when you see a TSH of 5 or greater, the endocrine world likes to suppress it because free T3 and VT4 can be absolutely perfect. And I see that often, but we like to treat it because we think it's not a good thing to have overstimulation to the thyroid. So frequently I will treat people who come in with a TSH of, let's say, 7 or 8, even above 5, more than a couple of times in a row. We define it, we see that it's Hashimoto's. And by the way, antibodies can go up and down, and so can the thyroid numbers. Every hormone in the body is not a fixed number, and it can change over time. So you can measure 1 month and things could look good, and you can measure the next month and they're different. So people should be aware of that as well. Don't rest your case just on one set of numbers.
All right, good advice. And this, I think, might be the last question. So we got
Great.
Lucy. Yeah, Lucy, do you recommend dietary restrictions to optimize hormones, especially for Hashimoto's?
That's an interesting question. I'm not sure what the definition for, Lucy is about dietary restrictions. It was Lucy, right?
Yeah, I'm thinking she probably, like a lot in the Hashimoto's world, as well as Graves' disease, what autoimmunity, a lot of times functional medicine practitioners, including myself, will talk about like eliminating gluten and like other like common allergens. So I think that's where she's going, but I'm not sure if she specifically means gluten, but if there's any specific foods for, yeah, I guess Hashimoto's or the, testosterone, estrogen, progesterone, or if yeah.
So that's a great question. I frankly believe that each one of us has to eat what's right for our body, but I also agree that it would not be an impossible thing, and it's not dangerous to experiment and eliminate gluten, for example, to see if you feel better and you get better. It's unlikely to affect an autoimmune disease like Hashimoto's, because an autoimmune disease is arising directly from your own cells. But can it calm down the immune system if, for example, you have difficulty detoxifying like me, or maybe celiac is part of it, and autoimmune diseases run together. So it wouldn't be a hard thing to do. Again, I'm not sure it would cure or fix Hashimoto's, and I think it might be distracting, or kind of even if Hashimoto's seem to improve, it could be temporary, and it could just have been what it did even if you didn't eliminate gluten. But it's worth trying. I agree that it would be worth experimenting that way. There's very few foods with respect to hormones, but the metabolism and absorption of hormones is affected by food. Like with thyroid, you have to fast in order to get the best result when you take your thyroid. And even testosterone and estrogen change with relationship if you're taking even the creams or pellets or a patch. In women who are menopausal and above, we don't give birth control pills because we don't want to absorb it through the oral passage. That's another topic, but we don't want the first pass through the liver because that can increase cholesterol. So no pills for women, let's say 45, 40 and older. And if they smoke, that's even more dangerous. So hopefully none of your followers smoke, I'm sure.
Yeah, hopefully not. And if you do, well, they know they probably shouldn't, but
yes.
Yeah. Well,
sometimes they have a wake-up call, and then it changes.
Yeah. Oh, it's true. My mother, she smoked for 40 plus years, and then she just got a little bit of a health scare, which, yes, and she stopped. So it's never too late to stop. So
exactly. Is she doing okay now?
She is, yeah. She's in her
Fantastic.
80s now, and yeah, she's lucky, because again, not everybody's good
Absolutely.
genetics, I guess you could say.
I know,
so,
and sadly,
yeah.
we know people who never smoke and get lung cancer at 30 and die. And then I always talk about, a woman blowing out at 103, blowing out all her candles on her cake, no COPD, chronic obstructive pulmonary disease, and no lung cancer. And she smoked 3 packs a day for her entire life. So that's where the N of 1 becomes very obvious to all of us.
Yeah, very interesting, and yeah, very excited to await the release of the Grok app. And thank you, Dr. Florence. Appreciate you taking the time. And yeah, and after we finish up, if you could just stick around for like half a minute, we just have to wait for the local recordings to upload. And then I'll let you go. But yeah, thank you for again, sharing everything. Thanks for answering questions, and everybody, thank you so much for tuning in. Appreciate it. Hope everybody has a great rest of your day and a wonderful weekend ahead, and happy holidays as well.
Thank you. And it was fun.
Yeah. Thank you.